Give me just few seconds. So everyone is 3, 2, 1. We are live with the attendance.
A very good evening to all the Indian Chess Society members as well as all the doctors who logged in Pan India today. My name is Dr. Neel Thakkar. Today we are here for a Indian Chess Society webinar and an academic discussion on single triple inhaler therapy and currently its utility in our obstructive airway disease in asthma as well as COPD. We are grateful to the Indian Chess Society, the President Dr. Rakesh Chawla sir, the Secretary Dr. Amita Nene madam, and the entire governing body to give us this platform where week by week pulmonologists pan India are updated related to the relevant topics. And currently, single inhaler triple therapy is a very debated as well as very discussed topic pan across all national as well as international academic discussions. So today I have a very esteemed panel as well as we have a very esteemed speaker with us. So we'll be starting first with the initial talk by Dr. Nagarjuna Maturu. So, sir does not require any introduction. Anybody in India who is a pulmonologist would recognize sir. He is a senior consultant and head clinical and interventional pulmonology with Yashoda Hospitals, High Tech City, Hyderabad. He has areas of interest in interventional pulmonology, in specifically lung nodules, as well as a member of the Indian Guideline Committee in asthma, COPD, so which is very relevant of the topic for discussion today. He's also introduced lung nodule clinics for the first time in India, and he's also the journal editor of the National Journal of the Indian Association of Bronchology, specifically for Annals of Interventional Pulmonology. So the list of his achievements are endless, but we hand over the mic now to Dr. Nagarjun Matru specifically to discuss regarding aspects of single inhaler triple therapy, practical case-based discussion. Thank you so much.
Thank you so much, Dr. Neel. Warm good evening to all of you who have logged in today. And also I should thank the ICS and Namita madam in particular for providing this academic platform, which has been running so well for the last year, more than a year, I should say. So as I continue to talk, let me share my screen. So I think this is a topic which every pulmonologist, every physician who is dealing patients of asthma and COPD has to know. And this definitely, the title I think is the very apt, because this is one thing, SITT, single inhaler triple therapy, has definitely changed the way we prescribe inhalers for asthma and COPD. So 5 years back, how we were treating COPD and asthma is not the same as what we are treating today. And that is mainly because of the introduction of this single inhaler triple therapy molecules. And India is in a very unique position because of the variety of options we have. As opposed to countries across the globe, the Indian pulmonologists have a new problem, that is to choose amongst the various options they have as to what would best suit their patient. So greetings from Hyderabad, Yashoda Hospitals, High Tech City. So data sources. So when I was making my talk, so obviously the Golden GINA guidelines are there. A lot of help from several pharma companies. Obviously this is there of AI. So we've taken some help from some of the AI tools and also medical apps like Tata 1mg. But what I will be talking is mostly what is my understanding and views about SITT. So before we go about briefly, how would I divide my talk? So what exactly is triple therapy? Is it beneficial over dual therapy? When to give triple therapy? And in particular SITT. Third is the most important thing. What are the options which are there for the Indian pulmonologist, a physician, to prescribe triple therapy? And how do we choose amongst the options we have? So this is how I would be going about. So what do you mean by triple inhalational therapy? This is something the basic. You have the combination of LABA, LAMA, and ICS. Again, you have 3 LABA molecules which can be used. No, 3 LAMAs: tiotropium, glycopyridinium, and metlidinium, and broadly 3 ICS molecules, either of these. So you can have permutations and combinations of each of these. And then I think in India, you have a lot of options now, which we'll be talking about. So how does a patient end up on a triple therapy? This we will be discussing when we talk about the indications again. You might either start a person on upfront triple, or you might step up to triple from a dual or a single. So if a person is on LABA LAMA, you add ICS, it becomes a triple. From ICS LABA, you add LAMA, it becomes a triple, or you add LAMA to ICS LABA. So this is important. And before we go on to the options, some studies which we should know, we will discuss very, very briefly. We won't go into the nitty-gritties of the studies. But is it better than dual? This is something first we should know. So COPD, asthma, both diseases we have landmark RCTs. So for COPD, I will talk to impact and the ethos. So these are the 2 trials which have actually led to the introduction of valid approval of SITT in COPD. Impact is for the combination of metlidinium, vilanterol, fluticasone, furoate. So what they have shown, this is a large study of several thousands or 10,000 people, where they've shown that triple as opposed to dual will significantly reduce exacerbations. Then the next landmark study is the ethos. This is for a different combination, that is budesonide, glycopyrronium, and fluticasone. Formoterol, sorry. So budesonide, glycopyrronium, formoterol. Again, they've used 2 strengths, and again they've shown in this not only did the exacerbations come down, the mortality also was better. So this is one of the first RCTs which has shown that there is mortality benefit with an inhaler. Similarly, the combination of impact and ethos, both of them have shown mortality benefit in COPD. So prior to these 2 trials, none of the pharmacotherapy, the LABA LAMAs, the ICS LABAs, they showed exacerbation benefits. They improved quality of life, but they never showed mortality benefit. So this is the third SITT, which is not there in our country. It is beclomethasone, glycopyrronium, and formoterol. This also has shown to decrease exacerbations. Now, if any of these trials, these SITT trials, be it the impact, the ethos, the chronos, tribute, so many are there. Consistently, what they've shown is the moderate exacerbations and severe exacerbations both come down. And all of us know that exacerbations have a very important role in the natural course of the life of the COPD. And what is important is this NNT. This is something we should understand. Number needed to treat with triple over dual to prevent one exacerbation. If you see for an impact L, it's 3 to 4, for tribute 11 to 12, which means the additional number of people who may have to give a medicine for the benefit to have. Here exacerbation is very, very less. So which means the magnitude of benefit of triple over dual is very, very significant. Then other thing is in which group it is more likely to be beneficial. Again, this all of us know, the eosinophilic group. So higher the eosinophils, better would be the benefit of adding ICS to LABA LAMA. That is about it. Again, this is another analysis, combined analysis of triple versus dual for mortality benefit. So this is the ethos and the impact studies again, which they have shown, and they've shown both of them have shown mortality benefit. And this is the gold guidelines. I think the last 3 years, the pharmacotherapy has come in the interventions with mortality benefit, and that was possible only because of SITT. And that is in these 2 trials, precisely the impact and the ethos. And also obviously every other outcome is also better. The quality of life will be better, lung function will be better. So in COPD, at least we have enough data to say that triple is better than dual, either LABA LAMA or ICS LABA. Okay, now coming to asthma. Do we have data for asthma? Yes, there are a lot of data, but this is one of the oldest studies I have taken. This is of adding tiotropium to ICS LABA in people who are not controlled with ICS LABA. These are asthmatics. And here the dose, here the device was Respimat, which is not there in our country, 5 microgram once a day of tiotropium. Again, they've shown that tiotropium decreases exacerbations. And you see the number needed to treat. Again, it's only 15. So the number needed to treat is less. Again, the magnitude of benefit is more. So both in asthma and COPD, there is data, enough data to say that triple is better than dual. So this is the first thing we should understand, that all of these trials, if you look at the inclusion criteria, they're not mild COPD or mild asthma. They're patients of severe COPD and severe asthma who have already are symptomatic, who are frequently exacerbating, and who needs escalation of therapy. That is important. Now, when to prescribe triple therapy? So because it is beneficial, you don't give it for everybody. So again, this we will use the gold guidelines here. I say 2026 now, because 2026 guidelines are out. So I will talk about the gold guidelines and GINA guidelines, and because that is what most of us follow and which is evidence-based as well. So in a patient of COPD, how do we give triple therapy? So first thing is called as upfront triple. So that is when you're starting the patient, you're diagnosing a COPD, you give triple as the first option. So when do we give triple as the first option? In group E. So again, group E means exacerbating phenotype. So again, the definition of group E has recently changed. 2026 has changed, which is even one moderate exacerbation. Earlier it was 2 moderate or 1 severe. Now it is even 1 moderate also would qualify for group E. So which means a vast majority of our COPD patients would be group E. So what is moderate exacerbation? Any exacerbation which requires oral corticosteroid would qualify for a moderate exacerbation. So a significant chunk of our COPD patients whom we see in our daily practice are actually group E. And if the group E COPD has an eosinophil count of more than 300, you can choose an upfront triple in this person. And there is a footnote. SITT may be more convenient and effective than multiple in a triple therapy. So when do we give SITT as the first option? Is if you have a group E COPD with high eosinophil count, you're not wrong in starting upfront triple. I think for most of the diseases, slowly we are evolving to hit hard first. Same is happening in pulmonary hypertension, from one monotherapy to dual therapy. Now we have come to triple therapy. Same thing for COPD also. I think we're hitting hard from the beginning so that we want to prevent as many exacerbations as we can. Now, the other way to reach a triple is by escalating. So this is the follow-up after the initial therapy. So if a person is on a monotherapy or a dual therapy, that is either a LAMA or a LABA plus LAMA, and he is exacerbating, then you can move to triple if the eosinophil counts are more than 300 or 100 sometimes. So this is another way we reach triple. In the dyspnea arm, if the person is symptomatic with breathlessness but not exacerbating, the gold does not recommend triple, but other guidelines, for example, the Spanish guidelines or sometimes the NICE guidelines also, they say even in this group of persistent dyspnea, you can give a trial of triple therapy and see if they're improving or not. The third algorithm, which again given in gold 2026, is if a person was on ICS LABA. If you look at the current guidelines, ICS LABA is not there in the entire treatment process of COPD. But if a person has been on ICS LABA before and he is symptomatic despite ICS LABA, you can go to triple therapy. So this is another algorithm for going to triple therapy. So 3 ways you can reach triple therapy: upfront triple, increase from LABA-LAMA or LAMA to triple because of his exacerbating, or ICS LABA will become triple if the person is symptomatic or is still exacerbating despite ICS LABA. And what it is said is because COPD is usually a progressive disease, from the diagnosis, if you closely follow them up, by the 8 to 10 years of diagnosis, most of them would have become group E and most of them would have been on triple therapy. So all COPD patients during their lifespan would eventually reach triple therapy is what the natural course of disease says. Now in asthma, when do we give? Again, if you go by the GINA guidelines, both tracks, the preferred track as well as the alternative track, if you see in step 5, before we think of biologics, you have to add on LAMA. This is irrespective of the phenotype of asthma. Be it T2 high, T2 low, it doesn't matter. If the person is not controlled on medium dose ICS LABA, he has to be on LAMA. So you don't have to go to high dose ICS. Medium dose ICS LABA uncontrolled, you go for addition of LAMA, because the benefit of adding LAMA is more than the benefit of increasing the dose of ICS. So all patients, before we think of biologics, we should give triple therapy, and that is what we follow also. Everybody whom we think of biologics are first around triple, and then they're still symptomatic, only then we think of biologics. Now the most practical part of the talk is how do we prescribe triple therapy in India? Okay. So broadly speaking, before this era of SITT, I would say this is a new era in inhalers. So before SITT, we had what is called as open triple or MITT, which means we were giving ICS LABA separately and LAMA separately, tiotropium or glycopyrronium, or we were giving LABA LAMA and ICS separately. So we were giving two different inhalers to the person. That's called an open triple or an MITT. But with the advent of SITT, I think everybody, except maybe for financial reasons, would prefer a person to be on SITT. That's called a single inhaler triple therapy. Again, there are two broad groups of SITT: SITT once a day and SITT twice a day. Now, the next thing we have to understand before we go into the options is how are the beneficial? Do we have data to say SITT is better than MITT? Yes, better adherence, better comfort for the patients, and I will show data, very strong data, that it is clinically more effective than MITT, and obviously also cost effective because they decrease exacerbations. It's very logical to say that adherence will be better. If you see, this is a real world study from UK. 6 months, 12 months, 18 months. The bar on the right side is the MITT, on the left side is SITT. You can see 100 to 200% more adherence with SITT. This is from US. Again, same 100 to 150% more adherence with SITT over MITT. This is from Spain. Again, this is a large study of 4,000 patients and very interesting data. Obviously, adherence is better. The blue line is SITT. But what is important is here the exacerbations are better. The same molecule you give as two inhalers versus one inhaler, the exacerbations are lesser. And very important is the mortality. Again, this is a real world study of 4,500 patients where they have shown that the mortality benefit with SITT over MITT. This is from China. I think each and every country has published their data that if you give SITT over MITT, the adherence is better. The more people persist, and this leads to better clinical outcomes in the form of decreased exacerbations and also improved mortality, improved survival. Okay, so SITT, as I've shown, studies across the globe from the Western world, from the Eastern world, consistently have shown that adherence is better, almost double. And SITT adherence leads to lesser exacerbations, better quality of life and symptoms, and also reduced mortality. That is the reason why guidelines uniformly say if we have to give triple therapy, better to choose SITT over open triple. So that is there. Now comes the complicated part, that is the options which we have. So if you look globally, for COPD, you have three combinations which are approved. These are called the innovators. So one is the vilanterol fluticasone umeclidinium by GSK, given by the Ellipta. That is the impact study. The budesonide glycopyrronium formoterol by AstraZeneca, given through the Breztri device, Aerosphere device. That is the ethos study. And the third is something which we don't have in our country. That is the beclomethasone formoterol glycopyrronium. This also is the tribute study. So these are three innovator molecules which have paved the way for SITT in COPD. But India, as I have said, has all of these except the last one and several more combinations. So in fact, even before these SITTs have come, India had SITT. So that is the tiotropium based SITTs. Tiotropium formoterol cycloserine SITTs in MDA and DPF form. But this, I would say, is not pharmacologically rational because formoterol always is twice daily, tiotropium is once daily. So this SITT, though it is still available, I don't think we should be using this. Now coming to the actual SITTs, which can be prescribed. Okay, so there are once daily and twice daily. So in once daily in India, we have three options. Okay, so for once daily, the LABA will be vilantrol or indicatrol. That is the ultra LABA. The LAMA, all LAMAs are once daily, except glycopyrronium, which can be once or twice. Okay, so umeclidinium, glycopyrronium as the LAMA, and the inhaler, the ICS would be fluticasone furoate or mometasone furoate, generally for most of them. So in India, we have three once daily SITT options. If you see, the top box gives us the molecule. Below, I have given this is the data from the 1mg app, which compares the various companies which have this molecule with this combination. If you can see here, 1, 2, 3. This is around 1 month old data. So we have 12 options of once daily SITT, and the costs also are there. Different companies are there, different players are there. Okay. So you have vilantrol, fluticasone, umeclidinium. This is the original combination. In India, we have vilantrol, fluticasone, glycopyrronium. And this is more for asthma, which has been studied. That is indicatrol, mometasone, glycopyrronium. So these are the three once daily SITTs which are there. Now coming to twice daily SITTs. Again, this is interesting because so many companies have these molecules. So here again we have, here the LABA will be formoterol. In the once daily SITT, LABA will be vilantrol, indicatrol. Here it will be formoterol. And LAMA can only be glycopyrronium because umeclidinium is once daily. And the ICS can be budesonide or fluticasone propionate. This is not ultra long acting ICS. That is fluticasone furoate. So here it is fluticasone propionate or budesonide. So here this is the BFG. This is the original ethos combination, the budesonide formoterol glycopyrronium, or the fluticasone glycopyrronium formoterol. So these are the two twice daily SITTs. So if you see in India, we have 5 different SITT combinations. For each combination, you have so many companies. And to complicate, you have different devices. Okay, now what are the devices in which SITT is available in our country? So SITT is available both as DPI and MDI. Okay, in DPI, you have this so-called single capsules, which can be used in any device, and you also have multi-dose DPS. So one of the standard is the Ellipta device or the SIP-Haler device. SIP-Haler is by Cipla, Ellipta is by GSK, and the general DPS which are already there. So that is the DPS. Then you also have MDIs. You have conventional breath actuated MDI as an SITT. You also have breath actuated or normal MDI or the aerosphere device, which is the AstraZeneca's device. So again, they have 3 different types of MDIs. Now there is another thing called as the SNTT. This is launched, I think, only this week. So you have all the 3 LABA, LAMA, and ICS in the same respule. I'm sure more companies will be coming up with this also. So if you have to give SITT or SNTT, again you have to choose the molecule composition. You should choose the device in which you want to give, and then you give the prescribe for the person. That is the options. Now, is there any data to say that one SITT is better than another SITT? So this is a question which is commonly asked. So unfortunately, we do not have a strong head-to-head comparison between the various SITT options. we do have network meta-analysis where they have compared one SITT combination with another SITT combination, and they have said some parameters are better with one, some with others, so on and so forth. But if you list down all the SITTs which are there in India, okay, these are 6 SITTs which are there. As I have said, tiotropium, formoterol, cyclosonide is pharmacologically incorrect. So that we will not talk about. Then you are left with 3 once daily SITTs and 2 twice daily SITTs. In this, if we go very scientifically, the large randomized data is not available for the formoterol, fluticasone, glycopyrronium and vilantrol, fluticasone, glycopyrronium. You have data for vilantrol, fluticasone, umeclidinium. Okay, so we'll move these 3 options. Now we're left with 3 which are backed up by robust scientific data, and this can be used. There is nothing that one is better than the other. It is just that vilantrol based is once daily, formoterol based is twice daily, and intacaterol based combination is approved mainly in asthma. So this is very brief, but it is not that others don't work. Others do work. We have given other combinations also. It is just that the data is not very robust. So in Indian patients, how do we choose the right SITT? As a doctor, scientific evidence, yes. Once daily versus twice daily. This is something which can help us choose between them. People who are adherent versus non-adherent, who are very symptomatic versus less symptomatic. Everybody has their own options, preferences. The device in which it is available. There are some combinations which are not available in DPA, some which are not available in MDI. So the device also has a role to play. Availability, many SITTs may not be available in the most rural parts of our country. So availability of the molecule also may be pictured in. Cost of the molecule, some of the multi-dose DPIs, the newer inhalers, may be little costly over the conventional single-dose DPIs. And lastly, the doctor preference and experience and the patient preference. So I cannot say that one SITT is better than the other, but definitely SITT is better than MITT. So I think with this brief overview of SITT, the various options, what to do and all those things, to summarize my talk, triple therapy is superior to dual therapy. I think this all of us would agree. You have lots and lots of data, but a small clause, don't prescribe triple therapy in all patients of asthma COPD. It is mainly for people who are severe asthma or severe COPD. That is gold E COPD, step 5 asthma, very simply put in. Then SITT is superior to MITT. Again, lot of data, lots and lots of data. So if you have to start a person on triple therapy, SITT is the way ahead. 3, there are lots of combinations in the Indian market, but only a few are backed by robust scientific evidence. And lastly, the best SITT for your patient has to be decided on a case-to-case basis. There is no one-size-fits-all concept in SITT. So we have entered the era of SITT. I think this is a complete new era altogether. And I'm happy that this topic has been chosen for tonight's webinar. I'm just hoping that I have made things clearer, not complicated for the listeners. So with this thing, I will like to thank my team who are always there with me. Thank you so much.
Thank you. Thank you so much, Dr. Nagarjuna, sir, for an excellent discussion and overview regarding SITT. And again, you made, I think, from the data that we have, more than 2,000 people are actually sitting with this SITT therapy talk. So a lot of people have logged in today. And so we'll now head over for a exciting panel discussion with all the respected panelists that we have today. I have the privilege of introducing Dr. Saibal Moitra. He's a adjunct professor and a senior consultant, Division of Allergy and Immunology, Apollo Multispeciality Hospitals in Kolkata. He's a visiting faculty is with the Allergy Asthma program in CMC Vellore. He has an H index of 17 with almost more than 100 international publications. He's a principal investigator and co-investigator in numerous international as well as national publications. Recently, he has also been part of the governing body member with the Indian Chess Society. So that's our first panelist for today. Second, we have with us Dr. Madhu Kanodia. She's a senior consultant with St. Stephen's Hospital, New Delhi. Madam is a part of a lecturer as well as a faculty in numerous national as well as international conferences. She's also a guide to DNB students and involved in training of nurses as well as allied health students. She has got a technical guidance book in tuberculosis and many articles on infective pulmonary mucormycosis perforation. She also has a very inclined interest in sleep apnea as well as nocturnal CPAP therapy for sleep apnea. So that is our second panelist for today, Dr. Madhu Kanodia. We have also with us Dr. Saurabh Mandilwar. He's a consultant chest physician with Cooper Hospital and Nanavati Max in Juhu, Mumbai. He is DNB from Leelavati Hospital. He's a consultant at various hospitals in Bandra, Khar, Santa Cruz, multiple with more than 10 years of experience. Was a frontline COVID warrior with Cooper Hospital. Also worked in critical care and pulmonary medicine. He's a member of the Indian Chest Society, ERS, and the American College of Chest Physicians. So welcome, Dr. Saurabh Mandilwar. We have Dr. Abha Mahasur, madam. She's a senior consultant, TNB IDCCM fellow in allergy and allergen immunotherapy with Vaidehi Institute, Bangalore. Currently, she's a lead consultant and pulmonologist with Leelavati Hospitals, Mumbai, and the scientific secretary of the Mumbai Chess Group. We're fortunate to have madam with us today. Thank you, madam.
Okay, now I would like to introduce Dr. Neel Thakkar, our moderator. Dr. Neel is basically based in Vadodara, Gujarat. He is presently working as a consultant pulmonary and critical care physician in Zydus Hospital, Vadodara. So he has 5 international and 5 national, 2 chapters and publications, and more than 40 presentations. He's a European diplomat in adult respiratory medicine, and also elected governing body member of the Indian Chess Society in 2025. He had numerous accolades and awards, like the Times of India Award for Excellence in Pulmonary and Critical Care Medicine in April 2025. He received a Certificate of Commitment awarded by the World Book of Records, London, for work done in the COVID-19 pandemic in March 2022, and was felicitated by the Chief Minister of Gujarat. Congratulations, Neel.
Thank you.
And it's a Chess Foundation Grant Award he has received 2019 for presentation of Chess 2019 in New Orleans, which is organized by the SSCP. It also received the ICS Grant Award for Base Research for presentation at ERS 2018 in Paris, which is organized by ERS. Okay, welcome, Neel, to today's webinar.
Thank you so much for the kind discussion, sir. Introduction, sir. Also, before we start the session, I would also like to thank our pharma sponsors for today. Lupin India has been sponsoring for today's session with the Indian Chess Society and the technical team who has been helping out with the entire presentation today. So we begin our panel discussion today. We've had an excellent discussion by Dr. Maturu on various options of single inhaler triple therapy which are available in India, as well as practical case-based discussion on the application of the various array of molecules which are also available, as well as different inhalers. So we dive into the discussion. My first question is to Dr. Saibal Moitra. What is the single inhaler triple therapy, the term that we are discussing today? And what is the actual rationale when we combine an ICS, LABA and a LAMA? Sir, please.
Yeah, thank you, Dr. Neel. I think Dr. Nagarjuna has so succinctly and precisely he has elaborated on this already. So I would just like to reiterate the same thing. When we talk about the triple therapy, it means that we are treating the patient with 3 classes of drugs. One is the LABA, long-acting beta agonist, LAMA, muscarinic antagonist, and the inhaled corticosteroids. Basically, the idea is we are actually targeting the 3 different pathways of the disease pathology. Like, ICS is an anti-inflammatory. Doing about the LAMA, we are actually preventing the parasympathetic driven bronchoconstriction, and LAVA is obviously the smooth muscle relaxation. So when all these three agents are combined in a single inhaler, that actually has been shown to achieve the various goals for the treatment that we have in our mind while we're treating a COPD or a severe asthma patients. So this is actually a scientific rationale, like when we talk about the single inhaler triple therapy in today's context.
Thank you so much, sir. So you rightly discussed when all the trials as well as guidelines now tell us that all the individual three components, if the ICS reduces inflammation, LABA causes bronchodilation, LAMA causes decrease in the smooth muscle tone. So all three benefit. My next question is to Dr. Madhu Kanodia, madam. When is early escalation to SITT therapy recommended as per both the latest GOLD guidelines, that is GOLD 2026, as well as the GINA 2025, both guidelines? When do you think of early escalation to single inhaler triple therapy, madam?
Okay. So basically, it is the Group E patients in COPD. Earlier, according to 2025, Group E was one severe exacerbation in the previous year that was requiring hospitalization, or greater than two moderate exacerbation in a year, previous year, or which has got a high eosinophil counts greater than 300 cells. But now, according to 2026, even a one moderate exacerbation in the previous year comes in the Group E. So it is the exacerbating phenotypes of the COPD. According to the guidelines, they require a starting of SITT therapy or a blood eosinophil greater than 300 cells per microliters. In the GOLD guidelines 226, they also suggest that even a blood eosinophil count above 100 favors the use of the patients for SITT. Those patients which are not adequately controlled on the bronchodilator COPD patients, either group A and B, and they're symptomatic, that is LAMA, LABA, or LAMA alone, they can be also added with the ICS, that is the SITT therapy. Then the asthmatic patients which are on step 5, they also can be started on SITT therapy.
Thank you so much, madam, for an elaborate and a summarized version of when we can use SITT therapy for both COPD as well as for asthma. Again, coming to Dr. Saurabh Mandilwar, what is the role of SITT therapy in COPD, especially in India, when we consider that the air quality index right now, last week we had news that in Delhi it was even reaching up to 700. So the pollution, even Gujarat now is reaching around 200. In most of the cities, we find there is a lot of air pollution. So, what is the role of SITT therapy, particularly with regards to pollution, as well as in the rural areas? We have a lot of biomass exposure or biofuel exposure. So, in such cases, does SITT therapy figure out better for India because of this? And what are your insights on this, sir?
Yes. So as you rightly said, Dr. Neel, in India, we have a certain different kind of scenario. We have a high burden of non-smoker COPD in India, which is almost 60% of the cases, which is different from the Western world. And we have a lot of biomol fuel exposure, as you said, air pollution. We have, yesterday we have got a news of Ethiopia, some volcano has erupted. A lot of ash particles are also coming to our country. So that kind of effect we have. As well as if you see, we have a high eosinophilic variability also in our population. One more point I want to say is the adherence, which is again a issue with Indian population. So considering all these things, definitely SITT therapy is more better, we can say, in Indian context. As I said, biomass related COPD is also very high in different pockets of the India, which has mixed inflammatory phenotype. And even the biomass related COPD is having significant small airway disease also. So adding a LAMA improves definitely small airway collapse also. So if you see criteria already we have discussed when to use SITT, but these things are there which is very common in India and which is more important using SITT. Adherence and technical errors are also more common with the use of inhalers. And even it is cost effective if you look at the cost. So that is also a point which favors the SITT use in our country more.
Thank you, sir. And again, like you've already discussed, even there have been national studies in our own country where there was a study published from India only, which showed that from Goa, in fact, that the specifically when biomass or non-smoking COPD is there, it is more eosinophilic type. So there is not the classic COPD, which is you find that there is more of eosinophilia when you have more biomass or bio pollution exposure. Coming to the next question with Dr. Abha Mahasur, where does SITT therapy fit in asthma? Where specifically when we talk about asthma, there is a lot of discussion now with a lot of novel biologic molecules coming in. So if there's an asthma patient who's on very high dose of inhaled steroids and is not improving, and he comes in with a lot of data from Google and ChatGPT, and he says that, okay, I want to take this biologic. So in this particular scenario, when do you consider that, okay, SITT therapy fits better compared to the biologics? And when do you figure that biologics are better, according to your experience? And please, madam.
Hi everyone. So Neel, I think the most important thing is that now we had enough data for COPD, but we also have enough data for asthma. So it's very clear that if you have an uncontrolled asthma on dual drug therapy, for example, LABA ICS, even if it is a medium dosed ICS with LABA combination not working for the patient, actually before you go to high dose ICS, we should consider for a triple drug therapy. That's the first point. The second point is there is no head-to-head data, but yes, even before considering a biologic, like very beautifully covered in our lecture, we should resort to first trying for a triple drug therapy before we go to biologics for our patient. So with this triple drug therapy, we've had enough data to say that there's going to be a reduced exacerbation for our asthmatic patients. It's also going to reduce the probability and the requirement of the oral corticosteroids for our patient. Plus, if you have a high dose ICS combination with the triple drug therapy, that is even better. So we have an even small airway disease with asthma, which is a genuine reality of Indian subpopulation. So we are in a win-win situation to actually first consider SITT in an asthma which is uncontrolled on dual drug therapy before we go to biologics. So I don't think that I completely agree with Dr. Nagarjuna, whether it is T1, T2 model which is working for us, but I'm sure the initial beginning step should be considering a LAMA to be added to the two current drugs.
Thank you. Thank you so much, ma'am, for providing an excellent answer as well as insights into guiding us in deciding for asthma patients. Nagarjuna sir, again, coming back to you after your excellent session is adherence. Like when we talk about adherence, that in India you find, especially where the patient is not that literate, or even the other side when the patients are over literate. In both these scenarios, you find that patient eventually stop inhalers. So do you feel that in patients to improve the compliance or adherence, if a patient is on multiple inhalers, does SITT help here? And is there any specific data to show this as per your experience as well as, please?
And I think there is beyond doubt that SITT improves adherence, and I've shown in my slides also. Data from every country, every part of the world has shown that the adherence rates double with SITT over MITT. And always we say Indians are non-adherent, but it is not just Indians, it is globally people are non-adherent. In UK, US, everywhere people are non-adherent. I think that is the general tendency, human tendency, I would say. So any step from our side which can improve adherence would improve patient outcomes directly. And that is what SITT also does. But SITT benefits are beyond adherence. So even who are adherent on SITT, equally MITT or SITT, they have shown that SITT has benefits beyond improving adherence. So definitely, yes, SITT improves adherence. And in our experience also, if we give 2 inhalers, I think it is very common. I think most of us will agree. The patient themselves will stop 1 inhaler. I will try decreasing 1 inhaler. If we give twice a day, the moment they become better, they'll do once a day. So I think this is called self-titration, which most of our patients do, and it happens. And only less than 25% of our any country population will stick to what we tell, at least after they become better. So once they are better, I think that is the time we have to switch over to SITT. And if it's on twice daily SITT, they are non-adherent, then definitely will come down to once daily SITT. So So that is what we follow. So if we find there is forgetful non-adherence or willful non-adherence, then we will try to counsel them and come to once daily SITTs. And that has been our norm for the last both asthma and COPD.
Sir, one more question we have from the audience I'll take with this from Dr. Mehek Agarwal. She has asked that will use of AI or digital inhalers now there are a lot of new digital inhalers coming with feedback. You have app connectivity, other newer progress with use of more digital knowledge. So will that improve and because you use tech so much in your own practice, do you feel that this will help in improving adherence even with SITT?
So there is one thing is data, second is practicality. In fact, Lupin only had come out with their Adhero device. Adhero is also a smart technology which would give feedback to the patient as well as the doctor on an app as to how good the compliance is. But unfortunately, it was not sustained, basically because the number of devices on which it can attach to was limited. Second, the patient's acceptance, understanding, all of this should be there. So to make utilize of this AI, the patient also should be technologically forward, and that may not be possible for a vast majority of our Indians. But definitely, I think, see, this is the way forward. I think the same has come for sleep technologies also. I think the sleep also, now most of the sleep devices are Bluetooth linked enabled, where the patients get their feedback, doctors get their feedback, so on and so forth. I think that is the way we are moving forward. There are a lot of companies which are now trying to bring in people and devices to ensure that the regular feedbacks are given. But I would say on the ground reality, it has not yet started. AI for improving adherence, but probably in the future it will be there.
Thank you. Thank you so much for an elaborate answer, sir. So coming to Dr. Saibal Moitra, sir, so what are the phenotypes? So when you think of that patient has a particular set of symptoms or the presentation, which phenotypes will you consider that this particular case, we had a discussion prior to this, but specific which cases where you consider early triple therapy? Like you start off with triple therapy or in the initial part when the patient comes to you. So please, sir.
Dr. Neel, I think this is now quite clearly stated in the guidelines. So we know that in the context of the COPD, if the patient are a frequent exacerbators in the gold E, so we upfront start the patient on a triple therapy. Now coming to asthma, we say that when the patients are in step 5 or step 4 rather, and they are not getting well controlled by ICS-LABA, so before going into the addition of biologics, next step is the addition of the LAMA. Now, when we talk about, again, coming back to the COPD, we now have the various phenotypes. So one I have said that is the frequent exacerbator or the GOLI. Other that is the interesting that is still, when we talk about is the echo. So when we talk about the echo phenotype, so that means the patients have like more than 40 years of age. The pheno may be quite high, 50, more than equal 50 parts per billion, or who have more than equal to 10 pack years of smoking history. So even this phenotype, they are also the frequent exacerbating phenotype. And diagnosing an echo, it calls for an upfront starting the treatment with an ICS-LABA and LAMA. And moreover, now when we are actually doing the phenotyping of the patient, we say that the biomarkers that we commonly use, that is the eosinophils. So therefore, a majority of the thrust is on the blood eosinophils. So any patients more than 300 per microliters, as they are the candidate for the ICS-LABA LAMA. But even if they're more than 100 cells per microliter, they even come for the candidate for the ICS-LABA LAMA if they're frequently exacerbating. So these are the components, or these are the kind of patients where we go and start the treatment with the ICS-LABA LAMA.
Thank you, sir. With this, I'll take a couple of questions from the audience because a lot of them, one is Dr. Vishwesh Shadambikar. He has asked, what is the role of blood eosinophil count. We've discussed the exact value. But with this also, there is another question from Dr. Lekha. What is the significance of blood eosinophil count in predicting the response? So one, you mentioned that when we start early SIT, but also do you feel that patients who have a higher eosinophil count will do relatively as a predictor of response? You expect the eosinophil counts to come down, or is it a predictor? Like, can you use it with triple therapy? So just please, sir, first, and then Dr. Maturu, sir, please. Yes.
Yeah, see, the one thing is that we know that more the eosinophils, the more likely to be the benefit from the addition of inhaled corticosteroids, because the corticosteroids mainly reduce the eosinophils, and we know that the eosinophils correlate very well with the exacerbation rates. So obviously means those who have the higher eosinophils, they are known to have a better response. But if you see that there is a subgroup of analysis even and in the Chrono study where they have found that even those who have lower eosinophils, that is more than 100 per microliters, there also the effect of addition of the SITT was quite robust, and there were clinically significant improvements in the various primary endpoints of the study as well. So yes, so coming to the question back, so if the high eosinophils, definitely you tend to means and actually deviate more on the SITT addition of an ICS. But even with the eosinophils up to 100, if the other context is there, then also we can say the response outcome by addition of steroids, it's definitely robust in the group of people in which you just characterize the other factors like the exacerbation rates and also the quantum of the symptoms or the symptom load in that patient.
Thank you so much, sir. Dr. Maturu, sir, you had raised your hand. So with that answer, just can you described a lot of molecules in India. So if a patient has a very high eosinophil count, is there any choice of molecule or just please, sir?
No, I think, see, the answer is very clear that if we are giving SITT with the aim to decrease exacerbations, then higher the eosinophil count, better will be the benefit. Because higher the eosinophil count, higher the chance of exacerbations. Higher the chance of exacerbations, more will be the benefit of ICS. So that is definitely there. If higher the eosinophil count, better will be the response rate for adding ICS to LAMA in a patient of COPD. Now the second question about will eosinophil count decide my choice of SITT, the answer is probably no. I don't think we have any data to say that one ICS combination is better than other ICS combinations as far as eosinophil count is concerned.
Thank you so much, sir. And again, the next question we come back to the inhalers. So we had a discussion of various types of inhalers as well as with the triple combination also, you have different types of inhalers. So my question to Dr. Madhu Kanodia, madam, does simplification of the inhalers that with a single type of inhaler, does it improve outcomes in patients in your practice, specifically for elderly patients, or if there are patients who have a lesser literacy or lesser understanding? Does it help in improving outcomes in your practice?
Yes, definitely. If you simplify the inhalers, it improves the techniques and outcomes in the elderly and low literacy patients. The word simplification means that there are less or fewer steps for preparation and administration. And you are not combining all the inhalers, there is a single inhaler, which is very important in patients which are elderly or low literacy rates, because these elderly patients might have cognitive decline, impaired vision, reduced fine motor skills. So the chances of errors are reduced. They understand, improving in understanding and handling. As a result, the misuse of the inhalers are less, improving the adherence. As a result, decreasing the exacerbations, improving the symptoms control, and achieving a good quality of life. For example, if a patient is taking a dry, like sir told, there are various forms: dry powder inhalers, MDI, soft mist inhalers, nebulizers now, and then you have a smart, which are not yet to become. So these dry powdered inhalers, there should be an appropriate when the patient can take forceful and deep inhalation. For MDIs and to a lesser extent, soft moist inhalers requires coordination between triggering and inhalation. Patient need to be able to perform a slow and a deep inhalation. If not more than then, if cannot, then we can switch to other. Overall, inhaler simplification combined with proper education, assessment, patient priority, his cognition, dexterity, strength, his literacy, clinical outcomes by mitigating the barrier of age and load literacy, leading to a better adherence and better symptom control, better reducing exacerbations, as a result, better quality of life.
Thank you. Thank you so much, ma'am, for a very elaborate discussion with respect to the simplification of inhaler therapy. Now, with this, I have a lot of questions specific to inhalers. So I'm taking parallel audience questions so that most of them who are here can get an answer. So one Dr. Anjali has asked, comparing the usability of a DPI, a PMDI, and an SMI device. Again, the question is with delivery of the triple therapy. So again, this is related more with the data. So either Dr. Maturu sir or anybody from the panelist, with utility of the device, one is the deposition of the drug and one is the compliance of the patient. So is there any insights from the panelists, please?
Basically,
Yes.
if you see the various studies, so the various studies which we see, we know that the studies are being conducted for a particular combination on a particular type. So like we have this the tribute, we have the trilogy, we have the Trinity, and then we have the chronocytos for the breast. So all these studies, they have consistently showed that the formulation of the device which was used, either we talk about the trilogy, we talk about the breastry or whatever device which was used, and they have found consistently almost equivalent results in the context of the decreasing in the exacerbation rates, in the improvement in the lung function, improvement in the quality of life, and also we have the mortality improvement as well. So we do not say that, well, this particular device will fare better rather than another device as far as the study goes. But everything boils down to the most important context, that is on a case-to-case basis. If you find that a patient and the physician, both of them are on the same page, and they decide that this is the choice of the drug and the device which the patient is going to adhere to, depending upon their choice and their purchase capacity, and also their ease of taking the technique, I think that's the best. So it does not decide upon that at a trial, but upon the patient who can use the device most effectively, that decides the final outcome of this treatment.
Thank you so much, sir. So as we have discussed, economics are important, ergonomics, how the patient is using is important, and the physics as to which pulmonary function test, like how is it is important. So again, with this one more question with the inhalers, we have Dr. Kripa. She has asked, what is the role of environment? Like basically, do any of these inhalers is bad for the environment? We talked about the people, but the triple therapy devices, the inhalers, do any of them have a environment implication that they are not good, and does that affect your selection or in policy making as per all of the panelists here?
Very happy somebody has asked that question. So I think there's been a lot of awareness in the last couple of years about the harmful effects of the MDAs. So I think DPAs are more environment friendly as compared to MDAs. I think if we have to talk only about the environment and the benefits to the environment, I think DPAs would score over MDA.
Yes, ma'am.
Actually the MDIs, they have hydrofluorocarbons, so they add to the global warming effect. So as sir is correctly says that DPI fares better as compared to the MDI.
Not only that, the plastic canister
Plastic
that also has
canisters,
to be
yes,
discarded.
yes.
So
Yeah,
you cannot reuse that canister.
understood.
So the amount of environmental pollution,
Mhm.
HFCs, yes, HFAs, yes, but even the canisters also cause pollution.
Pollution.
So,
You know,
so I think that way DPIs are more environment friendly than MDIs. I think that's it.
because
So do
now,
you feel that
yeah,
in future the inhalers, if the canister they give you that you continue that canister and inside you change the drug, do you think such things can work like
See,
as far as
HFAs are
the
better than CFCs, but none is better than any. So
Mm.
even
okay.
HFAs also have their
This is
environmental impact.
Yes,
That is
definitely.
also there. So that I think, see, the best way forward, I would say, is a multi-dose DPI.
multi-dosed.
Thank you so
Multi-dose
much, sir.
DPIs, I think, are the way forward. So they're more patient friendly, more environment friendly. I think these are the devices which I'm actually looking forward to.
Thank you. And it was a very insightful question also that when we talk about patients, we also have to discuss regarding the impact on the environment. So
And
now
one,
the next,
and one thing I'll just add to there is a multi-dose DPI. So they are now talk about the use of the biodegradable plastics. So that also goes in a way of this a device to be more environmental friendly. And we won't talk about the go green thing. So that's the way forward.
thank you.
One point I just wanted to add, like SITT MDIs, I think we should always ask to use spacer with the SITT MDIs, especially in Indian context. And probably sometime the patients having severe obstruction, that kind of negative pressure, probably they will not generate in severe COPD cases. So if we are giving MDIs, like always we have to prefer giving spacers also.
Definitely, especially if the patients don't are not understanding or you feel that may not understand the technique properly. Thank you so much, Dr. Saurabh. So the next question is to you only. What is the best indicator for response when you're using SITT therapy? At 3 months, what all do you feel needs to be assessed? How do you feel that this is a successful treatment or it's not working?
Okay, so like after 3 months, I would see, first of all, exacerbations are there or not. So this is my first criteria. Like patients should not have any exacerbation if my treatment is good, if I have given SITT. Even emergency visits should not be there. And even with the seasonal variation, like some pollution or some festival coming, like Diwali has come, that patient is stable during those conditions also. So all this symptomatology I will check in last 3 months. Definitely, if we go score wise, like we have different score, we have CAT score, we have MMRC, and we have SGRQ scores. So among the scores also there should be improvement. Like say CAT score improvement, 2 points improvements, we call it significant. And when we are talking about different scores, definitely we are talking about less rescue medicine use. Definitely we are talking about less shortness of breath, and definitely we are talking about less night symptoms and early morning symptoms. So this is the way we can ask patient, that patient is having, if you are doing spirometry, if like FEV1. So FEV1, like in some data say more than 100 ml improvement is there, suppose after 3 months. So there is no clear cut data. I would ask Dr. Nagarjuna to comment on that about FEV1 specifically. And that also I will see. So symptom load I'll see at the end of 3 month treatment. And definitely all the scores I'll check whether the patient is improved or not.
So again, considering with this, I'll take a question from the audience. We have from Dr. Jay. He has asked, how does SITT impact quality of life? You discussed regarding the CAT score. He's also asked regarding the St. George Respiratory Questionnaire and CAT both. So does it help in improving these scores or even in deciding when you routinely score your COPD patients or any patient with breathlessness and exertion? And do they help you in deciding the type of therapy as well as response to therapy, both? Please, Dr. Saurabh or anybody.
Yes, definitely. Just I answered, like same thing I have answered about the scores. Like
Hmm.
we have A, B, E classification. There also we have MMRC and CAT score. So definitely we are looking at it. And if I am looking at a particular score, so I am asking about rescue NLR, I am asking about night symptoms, disturbed sleep, each and everything we have to ask. And according to that, we have to see whether patient is improved or not. So definitely at the time of diagnosis and as well as response also. Both the things we have to score and see the symptom load.
And we have one more question from Dr. Fahim, why is inspiratory flow rate critical, especially when you're deciding a DPI-based triple therapy? So I'll also put it across this way that if a patient over the course of time you see the PFT, you find that you had started on an MDI but has a very poor inspiratory flow rate later on. So somebody has started and the patient has come to you. So would you change it to the device type, and is it important as a parameter for you? Inspiratory flow rate.
Yeah, I think this is a
Yes,
very
yes.
important thing. PIFR, peak inspiratory flow rate. In India, we don't have a very portable device, but I've seen such devices in outside countries where they actually check for the PIFR and then decide which inhaler best suits them. But whatever said, then see, there is also a school of thought that even patients of very severe COPD would be able to generate flow to trigger a DPI. That is what is there, unless until they're extremely sick. So yes, the flow rates do have an bearing on the choice of the inhaler. DPS would require a higher inspiratory flow rates over PMDS, and PMDS would probably require a little more than MTI with spacer. And then comes nebulizer. Nebulizer don't have to take a deep breath at all. So that is the order in which the PIFR requirement actually varies. But if you look at the data from any of these clinical trials, even irrespective of the type of device, be it Ellipta, be it the Aerosphere, be it the conventional MDI, all of them have recruited patients of severe COPD and severe asthma. So I think they all seem to be working well. So I think, yes, it is important, but only in the very small subset who are very, very, very sick. Otherwise, a vast majority of patients would be able to generate enough flow rates for any device.
So only a small point I just wanted to add if I have.
Yes, yes.
So like Dr. Nagarjuna said, the dials are very costly, which checks the peak inspiratory flow rate. But conventionally, suppose we have a 3-ball incentive spirometry device. If somebody conventionally, you can do that. If somebody can do just 1 ball, so you can give nebulization. 2 balls, one can do MDI, and 3 balls, if they can do, they can use the DPIs. So that is the way, suppose rural areas, they can select the device.
Definitely. And it's like a practical solution, but again, we would need, but it's a good even for a study to be done. I think it's a very good idea that way. Please, Dr. Mahasur.
Yeah.
So I think, as rightly put up by Dr. Nagarjuna, but I also feel this area needs a lot of feedback checking. So even if we start a patient on a particular device, it's very important that when we get the patient for follow-up, like especially the first follow-up after 1 month with the device should be there. So the best way to figure out whether this will happen or no is to actually see if the patient is able to perform the inhaler technique properly in front of you. And if you feel he is not able to generate the flows, I mean, this is something I believe we as chest physicians also have an eyeballing set. If we feel the patient is not able to generate adequate flows, it's always a good idea to switch the inhaler technique to something which we feel he can manage better, like an MDI with spacer, or if he cannot even do that much, then I think a nebulization.
One thing I would like to add, like if you look into the Ellipta device or the Aerosphere device, these are very, very low resistance devices.
Yes.
And they require very low inspiratory flow rate. So even we say that when a patient has been sent home after exacerbations, when they're fit for discharge, then that means these patients are able to generate that amount of flow rate to take the drug. So in that way means, well, you can choose any of them. So because these are very low, these new devices are very low resistance devices. They hardly require at least like 30 liters per minute flow rate or something like a very low flow rate that they need. So these are very, very effective, good devices even for the severe of the patients. If they cannot generate this amount of the flow rate, that means these patients are too sick to be sent home. This patient is exacerbating and need a nebulizer therapy.
Thank you so much, sir. Thank you. So this is kind of gives us an answer, and like Dr. Saibal sir said and Madam said that the best way is that you should see the patient with you using the inhaler to decide if this is best. Going forward, what are the red flags? This is for Dr. Abha Mahasur, madam. What are the red flags for? So everything cannot be always good. So what are the red flags that you see that okay, this particular patient this is a red flag where I will avoid the steroid or I will avoid de-escalating both that In this particular case, you will avoid using a steroid, inhaled steroid, so you will not prefer triple therapy. And in general, in this particular case, you will not de-escalate. So what are the red flags that you think you should keep in mind when you're using triple therapy?
So I think that we all know it's a beautiful regimen, but it may not be the apt therapy for every patient. So I believe the most important thing is to understand the candidature. Now, if you have a patient who's beautifully stable COPD, has had any exacerbation, just because the data is good, please do not add. So these are not the candidates for your addition of ICS and make them a SITT or a triple drug therapy. Then if you have a candidate where the eosinophil levels are less than 100, now these are not the candidates who are going to give us a great benefit of adding ICS to an existing LAVA-LAMA combination. So, I mean, adding that would not give you great benefit. So that is one thing which we won't do. Now coming to the, so whenever we talk about red flags with ICS, we are immediately actually thinking of pneumonia. So, but when we look at the data previously, we had still a data of 1 to 5% of patients with severe COPD may have pneumonia. The current data with all the trials which we have for current ICS and asthma with triple drug therapy, actually the incidence of pneumonia is less than 1%, which is like a huge relief. And the beauty of statement is it is irrespective of the choice of molecule. There is nothing like mometazone, fluticasone, budesonide, beclomethasone. They all practically have a similar efficacy and similar side effect profile by and far. Now, there are some relative contraindications, I would say, or rather, I would be very unhappy to see them, because if it is going to make a difference to the patient, I would rather sort of educate the patient, monitor the patient, but give the medication. But yes, we need to know that if you have a patient with a structural lung disease, say for example bronchiectasis or a structural lung damage where you have a colonizer, patient is going into again and again infection or pneumonias after starting, of course you'll have to come down. Or if you have a patient with unaddressed fungal lung diseases or tuberculosis, active tuberculosis unaddressed, relatively you have to optimize the disease and sort of manage it, steer the boat around that. Now, if you have someone who's actively smoking, now here this is not an absolute contraindication, but yes, if you have an active smoker, the efficacy of inhaled corticosteroid is poorer. So it is important that you sort of try to educate them, continue with the dose, but going to a very high dose is only a problem in a frequent pneumonia patient. Otherwise, I think we can manage everything around it if the patient is a correct candidate.
So with this, I'll also take, so we have a few questions related to pneumonia. One is by Dr. Karan. I think you answered most of it, but risk benefit evaluation when we initiate SITT therapy in a patient with a history of recurrent pneumonia. But with this, I'll just add, in the Indian context, there is a lot of tuberculosis. So if there is either an active TB or a latent tuberculosis infection, India latent TB is quite prevalent. So does that affect your decision when you're deciding triple therapy, latent TB, you, madam, and anybody else also?
No, I don't think so. See, if when you need, I think taking these two things parallelly is equally important. Just because you and me are treating COPD and severe asthma does not mean we don't treat an infection which is parallelly ongoing. Now, as of now, we are not treating, see, latent TB in lung should not be a problem. We are looking at a situation where you do not have an active disease. You treat both parts, I think, but don't try to withdraw ICS or make the patient suffer with COPD and asthma and not give ICS. You educate them how to minimize the side effects. Also, we can do one thing, that we actually do not go to a very high dose of ICS in such patients, but you parallelly treat your current ongoing active unaddressed infections. And by that, I mean active tuberculosis, active NTM, active fungal disease, and active varicella infection. These are the usual active infection where you have a data that ICS can sort of increase the pace of worsening.
Thank you so much, madam. And please, Dr. Saurabh, please.
So two things I actually want to mention. First of all, like suppose some asthma patient is there and we have started SITT and patient acquires the TB. So we never stop in asthma, we never stop ICS. We always give. Even with the patient is having TB, then also we have to, under cover of drugs, we have to give. And second thing, ICS, I think Gold has mentioned about 3 to 6 months gap. When we have stopped the TB treatment. So at least that kind of gap should be there if we are considering starting and we have options, a mild or moderate patient. So that kind of time difference, like you're just stopping the treatment and immediately you are starting, I think that should not be done if you have choice in COPD patient.
And even de-escalation also. De-escalation from triple drug therapy, like the second half of the question, it's a very tricky thing. Very, very tricky thing. If my patient is stable on a triple drug therapy, I would be very wary of de-escalating. Now, what we can do, if the patient has been absolutely stable with the exacerbation on a practical note till 6 months to 1 year, I may try to reduce the dose of my inhaled corticosteroids and see. But if I find any hints of any worsening in dyspnea or a slightest of exacerbation, I would rather not want to reduce the triple drug combination. There is a data which says that at the end of 5 years, 50% of triple drug therapy patient can be thought to be de-escalated. But you see the situation where we don't want to touch a functionally acting formula for the patient.
So this question, I'll put it for everybody because it is related to this topic. Dr. Ram Prasad Gurai has asked, how fast can I discontinue SITT after symptom control? And is there any golden rule for de-escalation that, okay, बहुत अच्छा हो गया, but we have to, he wants to de-escalate considering cost or considering patient logistics or patient symptom control. So anybody else from the panel on de-escalation specifically, do you follow any policy in your practice or any guidelines, recommendations?
Can I take it? I think
Yes,
I
yes,
would
please.
very much agree with what Dr. Abha madam has said. That I think the COPD and asthma is slightly different. For COPD, 100% what madam has said. If a person of COPD has reached to SITT and he is comfortable on SITT, then I think it is best to stick to it. Because the disease is such that it is a stable or a progressive disease. The only exception would be a person on SITT who has developed recurrent pneumonias and eosinophil is less than 100. That is probably the only reason when we might think. But asthma is slightly different because asthma by its nature has a fluctuating course. It's a disease which is known to go into remissions. It's a disease which may not always progress. So in asthma, if somebody is on triple and has been pretty stable for the last for over 3 to 6 months, then after decreasing the ICS from high to moderate, if at all, then we might step down from triple to dual, and which we have done in a number of asthmatics. But for COPD, I don't think I've come down from triple to dual for anybody, very frankly speaking.
Thank you. Thank you for sharing your experience, Maturu sir and Abha madam.
And I would
Yes,
like
madam,
to add
please,
one point.
please.
Sir has correctly said that in COPD there was a trial which was the Wisdom trial, in which they withdraw the ICS and they found there was a rapid decline in the lung functions as compared to those patients who were continued on the ICS LABA and LAMA therapy. So COPD behaves differently as compared to the asthma patients. Definitely the recommendation for ICS in COPD is the exacerbating phenotypes, which decreases the exacerbation. And most of the clinical trials like ethos, impact, chronos, either as a primary endpoint or the secondary endpoint, they have taken that moderate or severe COPD patients have decreased on triple therapy COPD exacerbation rates or mortality, increase in the trough FEV1 levels, and improving the quality of life.
Thank you so much, ma'am, for even providing scientific evidence. So we don't follow, as for antibiotic, we always follow antibiotic stewardship, not necessary for inhaler stewardship for COPD in specific cases. Now, because madam has discussed the impact and trilogy trials, there's a question, again, questioning these trials. So again, Maturu sir or anybody from the audience, that in the impact on trilogy trials, this is from Dr. Krunal. He has asked, in the impact and trilogy trials, what statistical adjustments were required to account for prior ICS use? So there were, like you discussed even in your case presentation, that there were adjustments with regards to the criteria of prior steroid use. And how does this influence our interpretation that SITT is superior? So again, this is questioning the criteria as well as the message is given through these trials. So anybody, if you want to take it up.
I think this is a very tricky question because we have to go through the criteria. I think Dr. Saibal sir can answer because it's been time I've gone through all this in detail.
Though I also haven't gone through in detail about the statistical design and everything, but you see that when one is doing a drug trial and like related to maybe a non-inferiority trial or whatever trial, okay, so with a new drug combination, so very important to understand that what are the primary endpoint you are looking at in that particular trial. So, and accordingly, we do the adjustments. So these are various statistical design adjustments which is done depending upon the heterogeneity of the populations, depending upon the primary endpoint, which is the main primary endpoint the study design is looking at. Now, at various studies, it is seen that a study is looking at the multiple endpoints. So, it's important to understand whether the sample population which has been taken to actually give the result for a single primary endpoint, whether that result holds true for the other endpoints which has been taken in the same trial as a primary objective. In that, we need to do some of the adjustments in the population. Like we have various adjustments protocols. Also, we do it either before or we can do it after, like the Bonferronis adjustments or before we have the adjustments. But there's a very important caveat. I'm very happy that somebody has taken up this question. Many a times it happens that, see, if we see that the primary endpoint is a single primary endpoint, say reduction in the exacerbation rate, and the sample size has been calculated taking into the effect size of that single primary endpoint. Now, many a times, the researcher might need to know that what are the other endpoints, which could be exploratory endpoints. So it's important to know that whether the adjustment which was done, it was in what fashion, in what heterogeneity, and whether it very clearly explains exploratory endpoints as well. So this is very interesting. Many a times in the statistical jargon, it gets hidden. So though nowadays we have very advanced statistics and we have the AI-based models, else and which can actually look into these adjustments, but these adjustments actually to somewhat reduce those exploratory endpoint and means actually the how we can very effectively judge the exploratory endpoint. So very important to know is that, and all these studies, they mainly look, the primary was as actually is the reduction in the exacerbation rates, with the other as exploratory endpoints. Only in the Chronos, there has been a subgroup analysis of that. This is the mortality, which is a very important thing, and also in that which has come up, which is a very interesting, but that was subgroup analysis, so that was shown.
Thank you so much, sir. So the message here is that we don't only look at the bottom line. We do need to see what are the exploratory endpoints, as well as in specific cases, what are the outcomes that are measured specific to these trials when we interpret them, not only the guideline endpoints. So again, now we'll come to some specific case scenarios. I would request all my panelists for short, specific answers as to what you will do, and specifically in these case scenarios, is it the right step and what other things could be there? So first, as an example, first with Dr. Saibal sir with you, 58-year-old male, is an ex-smoker. He has one moderate COPD exacerbation on LABA-LAMA combination in the last year. So if this patient comes to you, then would you decide that you escalate to SITT, or do you, like, how do you go about such a case?
Yeah, no, now it is very clear. Even one moderate exacerbation in a COPD patient merits that the patient should be put on the SITT. If the patient is on a LABA-LAMA and had a moderate exacerbation, even one moderate exacerbation, definitely this patient should be upgraded to an SITT.
So this patient, if the eosinophil is low, then?
See, the thing is that if the eosinophil low means how much? If the eosinophil is less than 100 per microliters, then in the adding an ICS, it may not be that beneficial. But if it's above 100, then even the above 100, this candidate can be put on the ICS level.
Thank you so much, sir. My next question for Dr. Madhu, madam. If a patient of COPD has a very high reliever use, like he says that over the last couple of months, I've had to use my reliever inhaler very frequently. Do you straight away decide to shift to this increased reliever use? Does it make you shift to SITT, or what else do you look at? Please, madam.
Means Increased reliever use indicates either poor control, inadequate technique, poor compliance. SITT may be considered to improve symptoms and reduce exacerbations. Now, it has been considered when patients are on adequate bronchiolitis, that is group A and B, still they are symptomatic, have symptoms, or they have exacerbation, then they are qualified for SITT therapy. FEV1 is one of the core outcomes which measures the disease severity and control, and evidence from meta-analysis indicates that when SITT is used, it is associated with the improvement in the lung FE1 absolute values, and even similar studies in asthma patients.
Thank you so much, ma'am. So in such a case, we look at the reliever use, but we also look at the patient's adherence to the actual medicine prescribed, whether they are taking or not, the other comorbidities which also might be influencing. But if everything else is controlled and the inhaler is used appropriately, in such cases, we can consider triple therapy. So again, my next question to Dr. Saurabh, if a patient is hospitalized under your care with an exacerbation is getting discharged, do you consider that after this exacerbation, immediately starting the patient on triple therapy, single inhaler triple therapy? Is this your strategy, or like how do you go about? Should it be started at discharge time or not?
Absolutely, absolutely. As like newer guidelines also says, only one exacerbation. Definitely, exacerbation is a criteria we have to start SITT. So, what device we have to choose, that we can judge as per the patient. And we have discussed this already. So, LABA LAMA, definitely I don't want to try in this patient on discharge. I'll put on triple therapy, especially like eosinophil count and all we have discussed, more than 300, more than 100 with exacerbation we had to give. And so that will be continued for probably a year or so. History also I want to know whether patient had pneumonia history or that kind of history or not. So my answer
Yes,
is yes.
also one question is, do you start at discharge? And one where you will definitely not start. Is there any case scenario where you will, okay, I will
So
definitely not start SIT therapy in this patient?
definitely not start. If you ask me, then again I'll go to the eosinophil count if it's less than 100. So low likelihood of any benefit of ICS probably in that condition. Still, and no history of like COPD, asthma, and not a frequent exacerbator. Then also in the new guidelines say you have to start. So majority of cases, I would say, I would start. Only thing is recurrent pneumonia kind of thing and eosinophil less than 100. In those conditions, probably I would not start.
Anybody else among the panelists when you will not start straight off at discharge?
Well, if the patient is had a bronchitis associated with that, definitely I won't start the patient on an SITT after discharge, because these patients can have
You are expecting a recurrent infection can happen. A
yes.
patient with active tuberculosis, again, you will be careful that in such patient you will not immediately initiate.
And also, if the patient is an ART, like an AIDS patient who has COPD exacerbations, these patients are not to be started.
Thank you, sir. So coming to Dr. Mahasur, madam, 72-year-old COPD with low BMI. He has a past pneumonia. Now, you know this patient's history. Patient has a very low BMI, is very frail, has had recurrent exacerbations. How do you benefit out the risk-benefit ratio of an inhaled steroid here? I think we've covered this to some extent, but specifically for this case scenario, this patient comes to your OPD. What do you do?
I think first we have to understand that having a history of previous pneumonia and having a history of exacerbation may not be the same. So if we look at it that this patient has had an exacerbation, then I think whatever be the BMI of the patient, adding an ICS would reduce the chance of he slipping into another exacerbation, because then he goes into category E, where we even a single moderate exacerbation. But now if we take it as an isolated content that this is a low BMI patient, elderly gentleman, presuming there was an episode of pneumonia, in that case, the most important thing for me would be to see if there are an eosinophil which makes him a candidate to be having an ICS on board. So if the eosinophil levels are more than 300, in that case, yes, we would add an ICS to him, but we will keep the dose in a little moderation because the BMI is low. He's pretty frail. Secondly, more importantly, I would feel that we should also continue with the rest of the armamentarium tick marks. He should be vaccinated. when we give ICS to any patient, especially in this situation where I know it is going to increase the chances of pneumonia, if at all, then we have to prime the patient about the proper technique, explain to him how to gargle religiously after taking the inhaler, and then monitor side effects on a periodic basis. So we have to make sure that in the OPD basis, how are we checking all these things every time?
Thank you. Thank you so much, madam. So we have one more question related to this, again coming from Dr. Krunal. What are the recommendations so Dr. Saibal touched on it, but what are the recommendations specifically for an immunodeficiency state when you're using SITT? And also with diabetes, somebody had asked, so if this particular patient has diabetes or a cardiac patient, in these three subsets, does your recommendation of SITT differ, madam, you or any of the panelists?
We have a very clear data. We call it like a major, MACs. So cardiac destabilization is not related to SITT. We have enough data. The only data we have from our three important trials is that there is less than 1% chance of pneumonia in these patients. But there is no data which says that SITT can deteriorate a cardiac condition or can deteriorate an immunocompromised patient. But yes, the logic says and the data says that if you have an unaddressed fulminating fungal lung infection, if you have unaddressed tuberculosis as a disease which you have to tackle, you first start with a definitive therapy, which should be followed up with the ICS if you need ICS.
Okay, thank you so much. Please, sir, please.
If we talk about the immunodeficiency state, one thing is quite clear that if a patient or an AIDS activates on the ART, these patients are not good candidate to be put on the SITT. Another thing that if a patient is having some primary immunodeficiency diseases, we say in the adults, what common is we can have the common variable immunodeficiency CVID. So we all know that the major is the Jeffrey Medal checklist. When you go through it, one thing is the repeated chest infections needing a lot of antibiotics, hospitalizations is one of the criteria when you do screening for these patients. So obviously these patients tend to have a lot of chest infections needing a lot of antibiotics. They are actually not good candidates to be put on the steroids, inhaled corticosteroids. But as the other Dr. Abha has very rightly said, for the cardiac and the diabetes, so that we have to see the risk benefit ratio and accordingly. But for the immunodeficiency, these two things are a bit clear.
There's one more point, Neel, that there are some patients who have a history of poor tolerance to ICS. Now, here is something which is a little clinical experience, that there are some patients who have recurrent oral thrush after you start them on ICS. And also, you also have to individualize your therapy. That's why I said that monitoring these patients where you know that they are in the red zone is extremely important when you start ICS. That I think gives you a lot of insightful direction on your own for your patient.
Thank you. Thank you so much. So the bottom line here is for immunodeficiency, we are very careful, or we do not consider inhaled steroids, or if we consider under very watchful guidance that the patient don't have recurrent infections. For cardiac and diabetes, more or less, it is safe, is what the panel agrees on. One more question that we have with regards to, for sputum eosinophilia or bile eosinophilia, we discussed a lot on blood eosinophils. So does sputum eosinophilia or bile eosinophilia impact your decision on triple therapy for the panel? Anybody can take.
So the practicality has to be pictured in. There is a lot of data that sputum and blood eosinophils go parallel to one another. There may be exceptions. You may have patients with sputum eosinophilia but no blood eosinophilia. But for all practical reasons, I don't think, barring a few centers in our country, sputum eosinophils is done on a regular basis. That is the reason most guidelines now talk about blood eosinophils and not sputum eosinophils.
Thank you so much, sir. So we have one case scenario for you. There's a Group E COPD patient who has a blood eosinophil 300, 2 exacerbations in the last year. So in such patient, if this patient comes to you for the first time, he's met 10 pulmonologists in your city and you're the 11th. So would you prescribe SITT first, or you will prefer LABA/LAMA in such a case?
Group E 2 exacerbations, eosinophils 300, blindfolded SITT, no other option.
Sir, one more question we have for the audience, that at what stage of disease progression, this is from Dr. Sanket Gadam, He has asked at what stage of disease progression so it is related to this case, that's why I'm asking, should SITT be introduced? Any stage of disease progression that you decide, okay, this is the stage I need to introduce triple therapy now?
So I think our threshold for introducing triple is slowly decreasing. That's what we have seen. And that is see, in COPD, the main reason for starting triple is exacerbation prevention. Dominant reason. So, and we have realized that preventing every exacerbation is important. Even one exacerbation, even one moderate exacerbation can have serious, long-standing cardiovascular and survival issues. That is the reason now the gold guidelines say even one moderate exacerbation in a person, you are not wrong in starting triple therapy if the person has an eosinophilic phenotype. That is where it is. So our threshold for starting is decreasing. So I think an exacerbating COPD phenotype, your threshold is very, very low.
Thank you, sir. I'll take one more audience question here. Dr. Sanjay has asked, this is related because a lot of impulse oscillometry is done now in most of the centers. So the question here is that explain how changes of airflow resistance, that if you're using a certain DPI and you find that the airflow resistance affects the delivery of the fine particle fraction of inhaled steroids in triple therapy. So does that help you determine that, okay, this is the particular type of inhaler or this triple therapy or the type of inhaler in specifically the airway resistance? So this is for you as well as any of the panelists.
Yeah, so can I take the question?
Yes, please, sir, please.
So if you're talking about the COPD, see then COPD, the role of the impulse oscillometry is very, very, very limited as of now, either in the diagnosis of the disease or prognostication of the disease, and we do not use it in choosing the drug delivery device or the drug. So why? Because we know very well that the resistance parameter, either we are measuring at the 5 Hertz or whatever the parameters or the reactance per parameters, these are very, very heterogeneous. And we do not know pertaining to the air quality, the air we are breathing in. So we do not have a very good, robust predicted equation to show that this is a disease, this is a non-disease. We have few regression equations, one for Eastern India and one for this. So please do not bring the oscillometry in making decisions with regard to the COPD. That is one thing. And another thing is that if we talk about that the which particle, which device is, so we know very, very well that this, when we are dealing with oscillometry, if we are seeing the resistance at the 5 Hertz or the resistance between 5 to 20 Hertz, which is a small airway fraction. Okay, so or we are measuring the reactance at the 5 Hertz or the AX or the FRS. These are basically a very, very heterogeneous picture which is getting. So, and it does not impact upon the overall drug delivery of a particular, the product which is there in the market. It does not has an impact on its application and usage. So there's no study, there has been no reports of that sort. So I don't think using an impulse oscillometry before choosing a drug delivery is really going to have an impact on which drug to choose. Rather, you can have it like peak inspiratory flow rate measurements. It has a better better thing, or maybe we can use those and see the patients, how the patient's inhaling. That is more practical and clinically applicable technique to choose a device and the drug.
Thank you so much, sir. You've thrown very good insights onto specifically usage of impulse oscillometry. With this, anybody else from the panelists would want to comment on specifically, because this question was related to airway resistance and small airway disease. So a lot of inhalers are marketed or told that this benefits for the small airway disease or specifically in combination. So in your practice, do you feel that having a small airway disease, any particular molecule or any particular device helps you more if a patient has a small airway disease? Anybody can take this.
So I'll just answer this thing. So it's very often discussed. See, we all agree that small airway disease play a significant role in the overall disease physiology and symptom burden. I think, see, people talk about extra fine MDIs, but I don't think we have extra fine MDS in the SITTs at least. No, we only have it in ICS lab, but that also availability is a major challenge. Now, if we talk about which drugs have been tested to penetrate small airways better, I think whatever I have gone through the literature, everybody else can add on to me or refute that the aerosphere technology has said to have a better peripheral deposition over the central deposition. But will that lead to any changes in the overall patient outcome as compared to other inhalers? I would say no. So I think that's all more of theoretical discussion. But for a patient, the end outcomes are, is my exacerbation better? Are my symptoms better? Is my quality of life better? I think these three parameters, all SATTs score almost equal to one another.
I
So I
agree
think,
with
yes, please, ma'am.
So we had data, I think COVID, when we all were fighting at that point in time, I think ciclosinide picked up a lot of market with the ultra fine molecule and the ability to reach. But I completely agree with Dr. Nagarjuna that these are all biochemical parameters where we say that the molecule is ultra fine. But remember that we all need such a molecule to stay in the air spaces as well. So when it comes to the clinical benefit being translated, that is where the data does not give you like a score over for these devices or these molecules as against say a standard fluticasone or a budesonide molecule. So we do have ultra-fine beclomethasone molecule, which got very hugely marketed beginning in the UK and then again it came down to India, which does promise that it's very fine and it can even reach to the bronchial finer levels, even to the alveolar levels. But the problem is we don't know whether it's going to stay there when the patient exhales. So clinically, we do not have any superiority trial or a data to say that only particle size can dictate the choice of drug.
Thank you so much, Maturu sir and madam.
And the last thing that I would like
Yes,
to
please.
add, that we know very well that if the disease is restricted only to the small airway, there's a silent zone. It hardly causes any symptom in the patient. So when the patient is symptomatic and quite severely symptomatic, it is not only that small airways, the other part of the airways has also been involved. So if it has been only been the small airways, it has been a silent, no symptoms, nothing, absolutely fine. But what we're talking in the context of SITT is a disease which has progressed much ahead. It is not limited to only the small airway part. So doing
Thank you so much, sir. So we have had a very good discussion on this. I have 3 or 4 questions only related to umeclidinium, so I'll take them together only if anybody wants to shed some light. So does OD umeclidinium help in patients with severe COPD? This is by Dr. Sanjay. Also, there is benefits of UVF, that is the triple combination of umeclidinium, vilantrol, and fluticasone. Specifically benefits. So I think part of it Dr. Nagarjuna discussed in his talk, but just your experience amongst all the panelists here, does this score specifically for severe COPD, this combination or umeclidinium per se?
The answer is yes. So they have been proven to work 24 hours and they've been tested in severe COPD only. So yes, we can give, but there's always a lot of, I think in every panel discussion of SITT in COPD, this question has been asked that in people who are very symptomatic, will once daily dosing suffice or should we prefer for a twice daily SITT? I think this is what the intention also was. So the answer is once daily works as good as twice daily, but every person is different. I have had patients who we had given once daily and they say I'm not happy, so we may have to switch to twice daily, and the other way around also. So I think at the end of the day, it is the patient's comfort and patient's preference which will decide whether you want to give once daily or twice daily.
And
Thank
even
you.
I think
Yes.
if somebody is working like job kind of profession, somebody is having, so once a daily is probably good for them, compliance wise also. Elderly person staying at home, probably for them BD doses are more preferably we can take like SITT with the BD doses. And cardiac safety wise also, we all know these molecules are very safe. That is again a good point about that.
Thank you.
One point I would like to add Though, as sir has said that the COPD patients, they fare good on OD dose also. But those patients which have a frequent nighttime awakening symptoms or early morning symptoms, they will require a twice daily dosing.
Thank you so much for all the respected panelists. Very good clinical insights. So, because we are talking about nighttime symptoms, again, next question to Dr. Saibal, sir. If a patient of asthma and you feel that this patient has an asthma COPD overlap, is a smoker, skin allergies, has overlapping symptoms, has a lot of nocturnal symptoms. So, do you feel that this patient is like you should start SIDT, or are there any other things also you'll consider, specifically if a patient says I have more symptoms at night?
So the one thing is that we know when we're using the medications, it's very important that these are quite long acting or the ultra long acting molecules. So those molecules like which are for the once daily, they give a very good 24-hour protection. But those who use it twice daily also give a very good 24-hour protection. But very important to understand that it is often that the patient prefers that, since if they have got a lot of there's the nighttime symptoms, they would like to have an inhaler before going to bed. So that actually this patient so twice daily preparations of an SITT. So this patient preferences are for that. And that is very important because we know that if the patient is in constant fear that maybe my taking once a dose is not enough, the patient might land up into taking another dose of a single OD SITT, and which might lead on to some serious adverse events. So these patients, I would prefer to be put on the BD SITT rather than going for the single OD once daily SITT. Though the trial says that both works good, but this is from the patient's perspective. And I've always done this. And these patients of this maybe echo, nighttime symptoms, allergic TT2 high, and along with that, the smoking history and 140 years. Definitely the BD SITT usually is preferred by myself, and also I see the patients are much more comfortable with that.
Thank you.
Dr. Neel, I have just,
Yes, sir.
if we are discussing, we can discuss about the rescue medicine also in both the categories. Suppose patient ask and patient is having symptoms, even with the OD SITT and BD SITT, both I'm asking. So what could be the rescue medication if we want to give? Like SMART, we had option of FB that can be given formoterol budesonide SOS also. But what about now we have OD and SITT, OD and BD both. So whether using SABA or you can say short acting ipratropium kind of thing is fine with the SOS medication with SITT?
See, the thing is that, again, now we know that if it's a patient of asthma who has gone into echo or whatever it is, so whenever we have to give a reliever, the reliever has to be an anti-inflammatory reliever. So that
Yes.
is it. So in our country, well, we have this beclomethasone salbutamol combination we have in our country. So usually giving a beclomethasone salbutamol would be the choice of the reliever to be given to these patients. We won't like to add the formoterol, but definitely these patients can have a beclomethasone, the salbutamol inhaler, which is there in Indian market.
So that is for sir asthma. It's a COPD. If some COPD you want to add something rescue.
Then
So
definitely it has to be a bronchodilator. It has to be like salbutamol inhalers could be used as a rescue.
So even the guidelines recommend that short-acting rescue medications, both Gina and Gold, still even with SIDT, you still use the rescue medications as and when needed. But specifically for this question, we've discussed regarding the triple therapy. But for nocturnal symptoms, we definitely adjust the therapy. But we look at other causes also. Is there any GRD aspiration? Is there any cardiac cause? Is there any other reason why the patient is having his symptoms? We've labeled it as ACOS, but with optimizing therapy, we rule out other causes also. Coming to the next question, we have for Dr. Madhu, madam, is the elderly asthma patient using 3 inhalers incorrectly? So, do you simplify it using SIDT? And I'll take one audience question with this. Somebody has asked, Dr. Krunal has asked, what adjustments are needed when you prescribe SIDT for elderly patients with poor dexterity? So both for this patient specifically, if 3 inhalers incorrectly, what will you use, and for poor dexterity?
Yes, simplifying to single inhaler triple therapy can significantly improve adherence. Now, it reduces the inhaler confusions. When you are using three inhalers, that too incorrectly, some of the patients will either miss the dosing, will decrease, or miss one of the inhalers. So, it improves the adherence. And there is a real world study which has shown that SITT was compared to MIT, that is, multiple inhaler triple therapy or open trial therapy, had a significant periods of mean proportions of days covered at 6 months and 1 year, leading to a better adherence. There was two group, one was the SIT group and MIT group, and they found that the persistence at 1 year was twice in the SIT group as compared to the MIT group.
Thank you so much, ma'am. So again, simplification does help in such cases, and coming to single inhaler does help. Now coming to the next, again, we have this similar patient, asthma with obesity, GERD, and allergic rhinitis, multiple comorbidities. So in this case, Dr. Saurabh, would you consider SIT therapy before using biologics or the other way around, and how do you decide? Like if this patient comes to you, how do you go about it?
So definitely yes. Asthma patient coming with obesity, GRD, allergic rhinitis. So I would step up to ICS LABA LAMA, obviously. And rather than if you compare with very high dose of ICS, so before putting on very high dose of ICS, I would prefer on SITT. And see, very high dose ICS, I would, again, we have discussed about the risk of pneumonia and other side effects of excess steroids. So what happens if I am adding LAMA in these asthma patients? Definitely it improves my airflow. Symptoms benefit is also there. All the trials say exacerbation reduction is there. And obesity associated asthma is more or most of the time is non-type 2 inflammation. So making ICS escalation is also less effective in these kind of patients.
Okay, with this, I'll also take the other way around, specifically for you as well as all of the other panelists. If which is a situation where the biologic bypasses SIT therapy in your practice or based on guidelines, anybody can take
No,
biologics before SIT.
nothing.
Nothing.
Nothing. So only indication is if you see before glycopyrronium had come, we were adding tiotropium after ICS lava, and there were a lot of people who were not tolerating tiotropium because of dry mouth or urinary retention or whatever. So then we used to stop tiotropium and go to biologic. But since the advent of the newer lamas, I think the tolerability of lamas also is much better. So now there are hardly any patients where we would give biologic before a triple therapy.
If
Can
a
I-
patient has a non-pulmonary severe allergy in such
Can
cases,
I add something,
No,
Dr.
that is different
yes.
indication.
Can I
Talking
add
about
add something? Like, yeah, though I fully agree with what Dr. Nagarjuna has said, but if we see that if the patient is having an asthma, which is a T2 high asthma, and this patient has a definite evidence of an aeroallergen driven disease, say like the house dust mite driven disease, which are very high specific Ig levels to dermatophagoid sphaerini on the teronicines, they're very high Ig levels, very high eosinophil levels, and these patients are doing very poorly with an ICS LABA. So these are a very small subset of the patients who might do better if we add a T2 biologic rather than again taking the patient through the pathway of a LAMA. If the patient has a very high specific Ig to aeroallergens, specifically like the house dust mite or maybe some cockroach allergens or the pollens, and with this allergen-driven disease, it is documented as patients and having a like nasal polyposis along with that, having allergic rhinitis, severe allergic rhinitis. So along with this, so these patients might be a candidate where we can think of adding a T2 logic rather than like going into through a LAMA. But if the patient cannot afford it, obviously the LAMA is another thing option.
Thank you so much, sir. So the bottom line here is that we individualize the therapy. We look at the IgE, the eosinophilia, if it is allergen-driven allergy, look the extra pulmonary, if there are any other severe allergies when we are deciding, and based on the risk-benefit ratio, economics, also we have to see when we are deciding on the biologic therapy. So again, coming to Mahasur madam, next question is if a patient of COPD is on dual LABA ICS therapy with multiple exacerbations, do you escalate this patient to SITT? Do you try something else? What do you do if this patient comes to you?
I think after towards the end of this discussion, it's just very simple. But
You have to
I think
sit.
whenever a patient comes to you, and I would always like to see how the story started. What was the rationale of giving him ICS? See, because we have a clarity in our guidelines in Goal 2026 that adding an ICS in COPD has to have a clarity of eosinophils. So if the ICS was added where the eosinophil levels were more than 100 to begin with, there is no brainer add a LAMA to it. But if the eosinophil levels were less than 100 to begin with, when the ICS got added by someone, then I think LABA LAMA continues to be a choice. The moment we talk about exacerbation, it is a triple drug therapy which we are looking at. So I think SITT is what we are looking at that category, because we are at gold class E.
So again, with this, I'll take one audience question. Dr. Raj Ratna Ganpat Bade has asked, and this is asked 10 minutes back, so we still have a lot of audience with us. So which is the role of spirometry for escalation or de-escalation of SITT specifically? So do you look at a PFT? You talked about an exacerbation. You're going to escalate or de-escalate. Does a PFT help you in deciding? And if yes, how?
So see, PFT will tell you about the grade of COPD. But eventually for our patients, there's a clarity that ICS is going to help us by reducing the frequency of exacerbation. So decision of adding ICS always usually is dictated by an exacerbation rate for the patient. But now there are some patients who can have less than 50% of FEV1, have had like other comorbidities, but still the data is very clear that if you have an increase in exacerbation, one moderate exacerbation, you add an ICS. So that's very clear. Now coming to the de-escalation of ICS, like I said, I would personally not want to make a stable system unstable. So if a person is working well on ICS and is having a good spirometry, I would not want to touch the patient for at least 6 months to 1 year. If after that also, if things are very good, lung functions have improved, patient did not have any exacerbation, I may try to first reduce the dose of ICS. But I would be very wary of stepping down from ICS, because we have enough data of deterioration after stepping down from ICS.
Thank you so much, ma'am. So considering the time as well as we will be going for the final messages, I think there are still a lot of audience questions which I have not been able to take. A few of them I'll just say these are for future discussion, but there are a lot. So Dr. Vishwesh Shadambikar has asked, will cost effectiveness drive for wider SIDT utilization globally? Dr. Pooja has asked, will the healthcare system adopt SIDT in the national policies? Dr. Farah has asked what gaps exist in the real world SITT data that need further research. So we always leave something for next time. So these are all questions which definitely the national policy, global utilization with the lesser cost, real world data. We have Dr. Maturu sir with us, who is driving the journals as well as he's academically. We have Dr. Saibal Moitra with us. We have all leaders academically here with us who can drive these discussions further into further research. So one take-home message from all of the respected panelists, please. Dr. Saurabh, we can start with you.
So I would say for SITT, 5 conditions: frequent exacerbator, high eosinophil count, a coke, fast decliners in spirometry, and the severe obstruction at the first visit. All should be started on SITT.
Thank you. Dr. Madhu, madam.
So I would definitely agree with this, that COPD phenotype exacerbator phenotypes. If you can, that is why in the Goal 2026 guidelines, they say that even a moderate, one exacerbation of moderate exacerbation, it comes into the group E, because it will help in decreasing the mortality. Whatever the studies has been done, impact and trials, the secondary endpoint after decreasing COPD exacerbation, they have found a mortality benefit. So exacerbating phenotype, eosinophilic phenotype, and those which have asthma COPD overlap, those which have hyperinflation, rapid fall or decline in FEV1, and severe uncontrolled asthma patients on medium or high dose Indian steroids before switching to even a high dose or biologicals, they need to be added LAMA, and hyperinflated patients.
Thank you so much, ma'am. Dr. Mahasur, madam, take home message.
Suggest your candidature should be perfect. If a patient needs to be, the whole game is about ICS and the side effect. If you have the correct candidate where you have data, it's going to help the patient with a significant eosinophil count. Don't worry to start the ICS. You rather monitor the side effects, educate the patient, and monitor the patient.
Thank you so much, ma'am. Dr. Nagarjuna, sir, you have taken us through the entire talk as well as you stayed for the entire panel. So, take home message.
So in the whole panel, we have been talking about SITT, give, but I think there is also a lot of overuse of SITT now because of availability of SITT. So we don't need to give SITT for a vast majority of well-controlled asthmatics and non-exacerbating COPD people. So please don't go home with the message that SITT is for everybody. SITT is only for Group E COPD and Stage 5 asthma, Level 5 asthma.
Thank you so much, sir. So it is a very good take-home message that when we have had a 2-hour discussion on SITT therapy, that does not mean it is a blanket therapy. We need to be very precise in the group that we are giving. Dr. Saibal, Moitra, sir, one take-home message.
Yeah, I would like to say that we now understand that everybody should make a point that SITT is the default mode treatment of the COPD. So while you are evaluating a patient of COPD, just first evaluate that which is the patient is not a candidate for the SITT. If you just tick those boxes, and if any of the boxes turns positive, don't put SITT. Otherwise, all the default mode is the SITT. So just stick to and see whether this patient is not a candidate for SITT while we're evaluating initial evaluation. If you do not find any, put the patient on the SITT.
Thank you so much, sir. And it has been a very good, elaborate couple of hours of discussion with regards to SITT as well as various aspects of obstructive airway disease management, diagnosis, troubleshooting, as well as we have had almost more than, I think, 60, 70 questions from the audience. We've had more than 2,000 people joining us today. So thank you so much to all respected panelists from across the country, all the audience that has joined us today, the Indian Chess Society, the governing body, Dr. Rakesh Chawla, Dr. Amita Nene, and the entire governing body, Lupin India, for sponsoring this session, as well as the academic partners and the entire technical team for the help. Thank you so much, everybody, and wishing you a very good night and hoping that you sit with the SITT therapy, but you also know when you do not need to give this therapy, so decide accordingly. Thank you so much to everybody. Thank you.
Thank you.
Mention to
Thank
Dr.
you.
Neel for the excellent moderation.
Thank
Thank
you.
Thank you.
Excellent moderation, excellent,
Thank you.
excellent discussion.
Yeah.
Thank you. Thank you,
Thanks a
everybody.
lot, everybody.
Thank you. Bye. Good night.
Thank you, Dr. Neel, for such an excellent session, and Dr. Nagarjuna for showing such an insight on SITT therapy, and all the faculty members and all the audience, please.
Thank you.
Thank you. Thank you. Think we can end. Yes, thank you.
Yes, thank you so much, everyone. So with that, I'm closing this link. Thank you.
Thank you. Thank you so much.
Thank
Good night,
you.
everybody. Bye.
Good night.